Hi, everyone, and welcome to the Pulmonary Content Review. This is the last of the 4 modules for Exam 3. The first concept we're going to cover is tuberculosis, and this comes in a couple of different forms. There's active and latent. Active is just that the patient actively has this disease. They don't feel well, they can spread it, can progress to death if not treated. Now, latent, on the other hand, the patient has TB, but the body has attacked it, has formed granulomas, and walled off this disease. So now it cannot spread. It can advance back to active, but for now, it's contained. Pulmonary issues don't necessarily happen just to the lung. They can happen to the pleural space or the serous lining that is located between the chest wall and the actual lung tissue. Here's a tension pneumothorax when there is a trauma, say a knife attack, CPR, like forceful chest compressions that have caused air to enter that pleural space, and that air starts to build up, causing collapse of that lung. The air is drawn into the pleural space during inspiration, and that causes it to separate more, destroying the negative pressure of the pleural space. This can continue to enlarge and shift even the opposite lung over as well, causing tracheal deviation. Now, if this becomes large enough, it can decrease the venous return to the heart, which is a life-threatening situation that does require decompression for survival. Another pulmonary issue that everybody's heard about is pneumonia. And in the picture here, you see on that left picture at the top, the alveolus are full of air, the bronchus is free and clear for air to go through. On the bottom picture below it is a picture in the setting of pneumonia where you have mucus, inflammation, infection in those alveolus, which causes the bronchus to constrict down with inflammation, or secondary to the inflammation. The most susceptible population to pneumonia, of course, are the immunocompromised. But thankfully, there are many processes in place to prevent pneumonia, including IgA antibodies in the nasopharynx, the mucociliary system, and pulmonary macrophages all help prevent you from getting a pneumonia. Another problem patients can have is hypercapnia, or increased PCO2. This is usually diagnosed on ABGs and can be a result of too many narcotics or benzodiazepines where the patient is not breathing effectively. This increase in CO2 can cause drowsiness and can progress to coma if this is not reversed. Now, pleural effusion is another issue that happens within the lungs, and that's a buildup of fluid in that pleural space between the outer lining of the lung and the lung itself. This can happen for two reasons. One, because of a lack of oncotic pressure or proteins in the blood that suck that fluid back into the blood vessels, and then that fluid stays in the periphery. The other one is exudative, and that happens in settings of inflammation, where you have that increased capillary permeability and the fluid leaks out. Now, people with COPD could have two issues going on. One is chronic bronchitis, and that's when those bronchus are filled with inflammation and excess mucus, as well as muscle constriction within those bronchus walls, constricting and decreasing the diameter of those bronchi. Emphysema, on the other hand, is a destruction of the walls of the alveolar membrane, and they become degraded and do not function as well as a normal alveolus. Now, pulmonary hypertension comes in two flavors, primary and secondary. Primary means it's a problem with the vessels themselves, not caused by an additional source. Here, it's the pulmonary vasculature lacking normal vasodilators such as prostacyclin and nitric oxide, and an overproduction of vasoconstrictors. In secondary, meaning it's caused by something else, it's usually due to heart failure or an issue with the heart altogether. Another problem is sleep apnea. Now, typically, patients that present with sleep apnea are men, obese people, and they typically describe daytime sleepiness, morning headaches. Their partners say they snore or actually might stop breathing and gasp in their sleep. The common cure, well, I don't say cure, but treatment for this is your CPAP devices. So lung cancer comes in two types. There's small cell and non-small cell. The small cell is about 20% and it's very malignant. Typically, when a patient gets diagnosed, it already has metastasized. Non-small cell is about 80%, with the most common being adenocarcinoma. Switching gears is a congenital abnormality called cystic fibrosis. And basically, what happens here is the chloride transport mechanisms are impaired, and the chloride gets trapped inside the cells. Sodium follows the chloride, and water follows the sodium. And then those secretions become very thick inside the lumen because the water has been sucked out. These secretions are retained and can obstruct the airway as well as cause infections. Now, this very busy slide describes everything you want to know about ARDS. Basically, at the end of the day, ARDS is very, very difficult to deal with and happens in acute settings. This can happen from a multitude of different sources, from fluid overload, from trauma. And in the next slide, we'll see what it actually looks like on an X-ray. Now, I think these x-rays really show what's going on with ARDS. On the left side, you see a normal chest x-ray. On the right, you see an x-ray with ARDS. And you can really see that capillary membrane at the alveolar level is very damaged. Now, when ARDS, that real fluffy, white, opaque lung picture, these patients are very difficult to oxygenate. And at times, they can be getting oxygen and completely not respond to it. And that's it for this pulmonary content review. I hope it helps. And let me know if you have any questions coming up to the exam. Good luck, everyone.